Okay, we're on live. Welcome, everybody. This is another series of the AO Trauma Hand North America online series, and a big hand to Chuck Cassidy and Marco Rizzo for putting these all together. Tonight's symposium is on scaphoid non-union, and we've corralled some renowned experts in this area: Dr. Jesse Jupiter, emeritus professor at Harvard; Kyle Bickel, who is a clinical assistant professor at UC San Francisco and director of the Hand Center in San Francisco; and Philip Blazar, who is chief of hand and upper extremity surgery at the Brigham and Women's Hospital in Boston. These are our disclosures. All of us have some relationships in some fashion with corporate entities, but none of these really, by my estimation, impacts this presentation. To control the chaos of many people attending the Zoom, the live cameras will only be on the faculty. Your microphones have been muted. There are normal two options for Q&A in Zoom presentations. One is chat, that will not be used. So any questions that you have, post at the bottom under your Q&A, and each of us faculty will try to monitor that. We have pre-selected some cases that hopefully will answer many of the questions, and so we may delay and answer them in the case of a case that's appropriate to that. Apart from that, we encourage you to be interactive, and we will field those questions as we go along. So at the end of this presentation, we hope that you'll be able to recognize the various characteristics and vascularity of non-unions, the stages of non-unions, the role for arthroscopy, how we recognize collapse deformity and correction of that, indications for vascularized bone grafts, and finally, salvage options for longstanding non-unions. So how the session will break down is we will interspace cases and discussion between major talks on staging, classification, and evaluation of deformity by Phil Blazar, non-vascularized grafts and defect management by Jesse Jupiter, and vascularized bone grafts by Kyle Bickel. We have additional advanced risk summits coming up. Note that they're every Thursday of the month except for the third Thursday of the month. So coming up are distal radial ulnar joint, followed by wrist arthritis, wrist arthroplasty, arthroscopy, and then at the very end, April 8th, we'll all pull together to summarize the take-homes from all of the advanced summits that have taken place so far. A link of tonight's recording will be sent to each participant through Zoom some 24 hours after conclusion, so you can review or go back and look at it as you want. So what is this about tonight? Well, as you know, the scaphoid is a little peanut of a bone, mostly covered by cartilage, and non-union relates to location of the fracture, collapse, displacement, delay in treatment seen in more than 50% of non-unions, and to some degree, factors interact with smoking, loss of vascularity, or impairment of vascularity, and concomitant carpal instability. So to set the stage, here's a 20-year-old student athlete, broke his scaphoid playing basketball, continued to play like often happens for 6 weeks, and then underwent a small dorsoarthrotomy, if you will, a percutaneous fixation with an Accutrack screw, as you see here. 5 months later, he presents to me with continued pain, resorption around the fracture site, some loosening of the screw, and as you see here, some dorsiflexion of the lunate and carpal collapse at the lunocapitate alignment. So what we hope to cover, through what we've set forth is, why did this fail? Is it collapsed? Is there vascular impairment in this case? How do we interpret the X-rays and MRI with respect to vascularity, and does it really matter? What are the options for fixing this? Of the various types of grafts, do we need a vascular graft or just a non-vascular graft? How do we intraoperatively assess correction of deformity? Some fixation options. And then very importantly, how do we know when it's healed? How do we know when to turn someone loose? And with late cases, what are the salvage options? So at this point, I will stop sharing and I'll turn over the podium to Philip Blazar for the next portion of the section. Phil, thank you.
Thanks, Hill. So my charge this evening, as part of this really terrific panel, is to talk about scaphoid non-union staging, classification, and a little bit about the role of arthroscopy. And so pretty clear what our learning objectives are, but typically just what the role of staging, classification, and imaging to help determine which surgical procedure we're going to perform to maximize our patient outcomes. I think it's really important when it comes to classification to be aware of a couple of things. So first of all, scaphoid non-unions, just like scaphoid fractures, we're all aware of the anatomical location as predicting a variety of things. So proximal, waist, and distal. But Tim Herbert, with the classification you can see depicted diagrammatically here, really brought our attention to the concept that scaphoid non-union is really a progressive process. And Herbert defined non-unions as injuries that were at least 6 weeks old. But over time, one typically progresses from, we believe, from D1 here, which is a fibrous situation with no deformity, to more of a pseudoarthrosis where there is subtle deformity, and then D3 where there is an advanced deformity and sclerotic pseudoarthrosis. And I think the diagram also you can see depicts that the length of the scaphoid there decreases over time as part of the three-dimensional process that occurs, as you can imagine, from the X-ray image on the left to the X-ray image on the right, where you've gone from an early non-union to one that's very sclerotic with loss of height, collapse, and in that image, secondary arthritic change. So it's this process of displacement, resorption of bone, and collapse that affects things. There are multiple studies that show that the probability of achieving union for a scaphoid non-union decreases with the time from injury, and several studies have shown that around 5 years from injury, while the probability of achieving union still exists, but it has significantly decreased than in the first months to 2 years. In terms of understanding the three-dimensional anatomy, I think the CT scan is a huge help beyond our normal X-rays. Certainly CTs are very helpful in terms of identifying the location and the obliquity of the fracture and or non-union. But in addition, in terms of the bony defect, what is the size, what is the shape, is there a sclerosis and cystic change? Well, one can get some sense of this on plain X-rays. The CT is very helpful. Typically, most of us are obtaining CTs in the plane of the scaphoid most of the time, although I don't find that that's always necessary. And I certainly still like to use the height-length ratio on CT, although it can be used on, can be calculated on plain X-rays and intraoperative fluoroscopy. And this is an image from Greg Bain's paper of almost 25 years ago, describing how to use that height-length ratio. The normal on CT is about 0.6. And here diagrammatically, you can see depicted the plane of the CT scan when it's taken in the traditional plane on the left and in the plane of the scaphoid on the right. This has been shown to be superior in the setting of looking for fracture identification when the CT scan is reformatted in the plane of the scaphoid. I also particularly prefer it in the plane of the scaphoid when I'm assessing for union. Moving on to scaphoid vascularity, a couple of landmark studies on this topic. Dr. Gelberman showed us that depicted diagrammatically in the image that the blood flow to the scaphoid comes in palmarly to the very distal component, but most of the proximal 3/4 of the scaphoid gets its blood flow from dorsally, as you can see depicted there. Dr. Green also described and correlated this with the probability of achieving union, that looking at the proximal pole, there were those scaphoids that showed normal, some that showed diminished, and some that showed complete lack of punctate bleeding, and correlated the probability of union with these three types or visually seen at surgery findings. In terms of identifying avascular necrosis, this image from the Merck manual, so directed at general medical students and people, this is the image of proximal pole avascular necrosis, demonstrating that the proximal pole is sclerotic on plain X-ray. Multiple studies have shown on a variety of times that actually this does not correlate particularly well with either surgical findings or the probability of union. So unfortunately, it's not quite that simple. And in fact, when we go to look for AVN in 2021, looking at how do we identify it and how well do we identify it, the further one goes into this, the more complicated it can be. So certainly MRI has been correlated superiorly to plain X-rays and to other imaging modalities in terms of identifying it. However, the numbers comparing it to punctate bleeding as the gold standard are not all that great, and the accuracy rate is only around 80% in most of the literature. MRI, including dynamic contrast enhancement, has been proposed as superior to MRI without contrast, but the currently published studies are actually contradictory with each other in terms of if this is really distinctly superior. You add a case like Hill presented at the beginning with a metal screw or other source of metal artifact to MRI, which is notoriously degraded in signal with the presence of metal, and I think all bets are off. Interestingly enough, in terms of looking at avascular necrosis, those studies that actually look at histology of proximal pole scaphoid bone that is removed and thought to have abnormal punctate bleeding or noted to have abnormal punctate bleeding, when you look at the viability of osteocytes, the majority of those, even scaphoids that don't have any punctate bleeding, do show some significant percentage of viable osteocytes. So how truly osteonecrotic is a so-called avascular scaphoid, I think, is a matter of still some debate. So transitioning to the role of arthroscopy in scaphoid non-union, certainly the rationale makes a lot of sense to those of us who do arthroscopy and wrist surgery. Preserving soft tissues, particularly vascularity, in this clinical scenario makes a lot of sense. But there are two real questions that arise from that. Number one, can you use it to correct deformity? And does the theoretical rationale actually translate into faster union or superior union rates? And the best study that I'm aware addressing this topic is by published in the journal Arthroscopy 2 or 3 years ago, which are a fairly sizable series of about 30 open and 30 arthroscopic procedures. And you can see the image from the study here demonstrating the technique, including in G, the bone graft, and the pre and post-op x-rays. But the bottom line of the study was that union was not different. Clinical outcomes were not different, but actually the ability to obtain a correction of the deformity of the scaphoid was less noted at arthroscopy than at open surgery. So why don't we jump in and do a case. So this is AG. This is an 18-year-old young man who presented with wrist pain, as commonly happens, as Hill suggested, about 6.5 weeks after a fall. Initially presented to an urgent care center who diagnosed a non-displaced scaphoid fracture and gave them a thumb spica splint. The patient then subsequently presented to my colleague Andrea Bauer at Boston Children's with minimal pain. And these are the injuries on presentation, the X-rays on presentation. And I think you can see, I'm going to go back once or twice, that this does appear to have a fracture line, but it's in this plane, which is somewhat unusual. And so this individual, to better understand, as we commonly do, obtained a CT scan. And hopefully, I think you can see these images. Now, this is a CT scan not formatted in the plane of the scaphoid, but I think Ford deciding that this is clearly a non-united scaphoid with a somewhat unusual plane of injury is perfectly adequate. And here are the images in another plane just running through here. As you can see, again, this displaced non-united scaphoid. And so these early non-unions, if you like, certainly meet Dr. Herbert's definition of non-union, more than 6 weeks from injury. I do think this case brings to light the tension in scaphoid non-union surgery between biology and, if you like, musculoskeletal carpentry. 2 months out from injury, but in an 18-year-old, I think biologically these may be somewhere between typically what we think of a fracture and a non-union. And then in this case, the carpentry, I think, is interesting because the plane of the fracture is somewhat atypical. And so the fixation may need to be a little bit atypical. And so what was done with this case, so certainly it was addressed with a volar approach here, and there's a freer elevator in the plane of the non-union, which was used to achieve a reduction, provisional fixation, and then a retrograde K-wire down the scaphoid. The decision was made here to place the screw in an antegrade fashion over that wire that was placed perpendicular to what they perceived was the plane of the fracture. And I think you can see the intraoperative fluoroscopy views here. And here is an early image at 10 weeks, which looks like showing union. Interestingly enough, this screw is intentionally not placed in the traditional center position based on the deformity of the fracture. And I think there are times, certainly with some, and this is an image from another case with another scaphoid in a different obliquity, atypical fracture pattern, which demonstrates that sometimes we have to be creative with our hardware fixation to gain superior fixation for the given injury in a given case. So I'm going to transition to a second case of mine. This is SH, presented with right wrist pain. This was a 22-year-old female college soccer goalie who presented a year after injury. She had persistent pain. She had an X-ray taken the week of injury. As happens with many of these folks, no fracture was noted. She returned to play, but was symptomatic for the course of the year. She continued to play goalie, but this was very limiting. And here are her plain radiographs at a year. Pretty clear that there is a fairly proximal scaphoid non-union. On the X-rays look to have a cystic change, but the CT scan, I think, gives us a little bit more information about the amount of bone resorption and the architecture of the scaphoid here. So certainly for me, the key things about this case is that there is significant resorption at the non-union site, but there is no evidence of collapse and no significant displacement. And so the three-dimensional shape of that scaphoid, I think, is relatively preserved, but has this cystic defect. The other interesting part of this case is it's a quite proximal, really quite small fragment. And so elected to address this with a dorsal approach. The non-union was opened up and curetted out to address that cystic resorbed area. And then a cancellous graft was taken from the area of Lister's tubercle. You can see the markings on the scaphoid that we made because the non-union was perfectly anatomic. Prior to opening up and cleaning it out, the screw was placed using a cannulated headless screw in an antegrade fashion, and the fluoroscopic images demonstrating just how small this proximal fragment was. Early X-ray signs of healing at 6 weeks when she was released from the cast, and CT scan at 10 weeks before we released her to documenting union before we released her return to intercollegiate soccer play as a goalie. And with that, I'm going to say thank you and turn things back over to Hill.
Super. Thank you, Phil. So we'll move on. So here's a case by my friend, the late Joe Slade, from a publication with Greg Merrill, a proximal non-union, again, pretty well aligned, a little bit of cystic deformity. So it brings up the point that you just mentioned about whether or not these non-unions do have osteogenic capability. And along with that, Phil, is there a reason to debride the fibrous site in these small non-unions along with grafting and fixing? And then Jesse, I'll ask you subsequent to that, if you do graft it, what are your options for grafting it? Is it BMP? Is it allograft? Is it autogenous graft? Phil, what do you think about debridement of the site?
Thanks, Hill. I do think some of these fibrous non-unions do have the potential to heal. So unionogenic, including osteogenic. For me, if I will see an intact cartilage envelope, which I sometimes will see with some of these proximal, truly non-displaced injuries, I won't necessarily take it down. In my case, like in this one, if there is something of a cystic resorption, I do think replacing it with bone graft, as Slade's case did as well as mine, I do typically do that. But I think some of these do have the ability to heal just with stabilizing with the screw.
And Jesse's options for graft?
Yeah, the first thing is rarely do I get the K-wire down the first strike correctly. So by putting it 2 or 3 K-wire passes, you're inducing some degree of vascularization. And if I had to do a graft, it would be just a pure cancellous graft.
Okay, thank you. So here's the proximal pole, similar proximal pole, maybe very slightly displaced. What happens when you have even a smaller fragment, Kyle? With smaller than it seems like you might be able to fix with a standard screw. What are the options with even a smaller proximal pole fracture?
I do think you have some other options. First, please don't forget the K-wires. I use them, when they are the best option. And in cases like this, where you have extremely small fragments, they can be the best option. It's always tempting to make a good looking X-ray with a well-placed screw, but some of these screws, especially the conical screws like you see in that far right image, have a pretty high compressive and expansile potential as you put those last 3 or 4 turns into it. And I've had the same unfortunate experience that most of us have had of, getting a perfect reduction on these small fragments, being tempted to put in a screw and everything's going great until that last quarter turn when you watch it explode before your eyes. So K-wires are a great option for small fragments. I usually use 2 or 3 if I can get 3. And I try to then put some stabilization from the radius across the scaphoid into the capitate as well. Because as we know, K-wires are good for fixing fragments, but they're not rigid fixation for the scaphoid or for the carpus. So you have to be a little bit careful about providing a good stable construct for healing. But I do use K-wires.
Super.
The other thing to mention is taking these down. Often we just look at the non-union and think, let's go straight across it. But in doing so, you debride a lot of what's left of that small proximal pole. So you can make a vertical trough across your non-union site, leaving the cortical shell intact on 3 sides, and do a lot less architectural damage to that non-union than you would with a transverse debridement. So it's another option, and I'll show a case of that later.
Super. This slide on the right, the picture on the right, pretty large screws. This was a favorite of Joe Slade, but he was also a fan, Jesse, of putting scaphocapitate screws in certain instances beyond just the scaphoid screw. What's the reason, and when would you think about doing something like that?
Well, if you
Jesse.
particularly realigned an unstable non-union, you'd like to take as much stress off your internal fixation as possible. And so this would be a temporary fixation from the scaphoid to the capitate. Especially with a small proximal, I've used 1.5 millimeter screws. Even screws with a head, you can put the head down just below the joint surface and get a very good compression. Some of these small headless screws don't really give you very excellent compression.
And sometimes you can even put 2 small screws in. So
Exactly.
they obviously come as a standard like this, a mini, and then there are micro screws as well.
Right. Exactly.
So this will turn the podium back over to Jesse to talk about non-vascularized methods and graft and non-union deformity.
All right. I've got to go. Sorry. I got to go back to my starting. We were practicing.
Practice makes perfect, but
Yeah.
but you never know what's going to happen, do you?
Here we go.
I'm an
Okay.
example of that.
You know, if you look at this diagrammatic chart of scaphoid non-union, you realize that we may not always be talking about the same entity. There may be a proximal pole, there may be waist fractures with arthritis or without arthritis. There may be fracture non-unions with problematic arthritis or carpal instability. Diego Fernandez, who's in Switzerland, came up with a very nice approach to think about these things. And one thing we just touched on is a fibrous non-union. And when it's stable, without deformity, without collapse, these have an excellent prognosis, and grafting is not always necessary. And if grafting is considered, it's not necessary to be structural. Once you start having a larger defect or mobile non-union, even those that may have a pseudarthrosis, these may have an instability pattern, and anterior grafting may be able to not only reduce the malalignment, but also provide a structural or non-structural graft, as we'll touch upon. Once you start getting this position, as Dr. Blazer showed, we start having more problematic, and we have to start thinking about the age and the symptoms with carpal arthritis developing. And as was touched on, and Kyle Bickel will talk about this more, is there a need for a revascularization trial for some of these very proximal pole avascular situations? I'll try to stay with the non-vascularized grafts, and Kyle will talk about vascularized and other alternatives for this. So let's look at the waist fracture level. There's a well-aligned CT scan and no cystic changes. And this really is well handled with a non-structural graft. This is a young man with a typical presentation 6 months after an injury, and pain and limited motion in his wrist. And his x-rays showed exactly what Dr. Blazer was showing, where there's a suggestion of avascularity or radiodensity, but rarely are these truly avascular. And you can see on the CT, there's a little bit of a dorsal osteophyte, but the alignment is reasonably within normal limits, and another CT view. And so this is approached through a dorsal incision, and not only identifying the non-union, but decorticating with a small drill or K-wires on both sides to induce osteogenesis from the bones themselves. And I've never believed in this punctate bleeding situation per se. And then packing this with cancellous graft. And you realize that this is a three-dimensional deformity, so you can get a lot of graft in, and it will fill very nicely all the surfaces of the non-union. And then a headless screw placed, and here's your picture. And notice the radiodensity early on, but it does heal. There's a little radiolucency around the screw distally, but a functional outcome. We've also realized that treating a deformed non-union with a humpback can be done also without structural graft. And this is an article in Mark Cohn and colleagues in the Journal of Hand Surgery. I found that if you take a small syringe and take out the plunger and put in your cancellous distal radius graft and then compress it, you can then come out with a fairly compact compressed cancellous graft. And as illustrated in this case, the realignment is done and a very stable headless screw is placed. And this graft is filling the entire surface of the deformity. Once you start getting cystic changes and a humpback deformity, then we start to find the role of corticocancellous bone and a volar approach, whether using struts of either distal radius or iliac crest, so-called Rusi graft, or a wedge graft taken from the distal radius will achieve this reasonably well. Realize that in these deformed non-unions, they may be, as described by Stephen Villegas, a volar type or a dorsal type. So it may be different, and that's why CT, as Dr. Blazer said, is critical in analyzing these. The advantage of this is that you not only are restoring the anatomy, but hopefully realigning the carpal kinematics and maybe slowing down the progression for osteoarthritis. The standard approach in many books has you paralleling the flexor carpi radialis and cutting straight across the volar radial scaphocapitate ligaments. But in trying to avoid that, Mark Garciolitis came up with this idea of creating two flaps. And then by doing this and closing them in sort of a Z-plasty fashion, you may have less traumatic injury to those ligaments. So here's a volar type classic deformed non-union, and taking out the deformity and creating a space, as Kyle Backel talked about, for the graft is paramount in getting length and stability. And I agree, it's not absolutely necessary always to use headless screws. K-wires can be very effective in these cases, but once you've got the structural graft, it may be very stable. This is a case, you see this type of non-union, and opening this up and creating a big void, decorticating both edges so that there's healthy surfaces, and reducing it by extension, ulnar deviation, and bear in mind that there may be a rotational deformity of the distal half. So sometimes you need to do a rotational control, placing the graft, and here's your K-wire, and then headless screw. And a final case with a carpal instability pattern, the volar approach here. Again, decorticating, opening up and realigning the distal half and placing a wedge graft in, which is a fairly robust amount of bone, headless screw, and then a careful repair of the volar carpal ligaments. And here the realignment of the carpal situation as well. So if we look at the best evidence in the literature, both wedge structural graft and non-structural graft, both are reproducible with moderate evidence, good outcomes. And it doesn't appear to have a difference in the union rate between the two grafts types. Structural grafts will help you correct the carpal malalignment better than the non-structural grafts, and may be associated with the better functional, although the evidence is low. But long-term findings suggest neither these approaches will prevent OA, but may slow it down. In my experience, 90% of cases, including those with so-called scant bleeding points, have healed with interpositional graft and stable internal fixation, putting it only about 10% that require a revascularization procedure. And especially, as Dr. Blazer pointed out, bone vascularity has not really been identified very well in clinical reports, and it's very hard to really appreciate the effectiveness of vascularized graft compared to conventional techniques. Thank you.
Thank you, Jesse. Yeah, it's interesting that observations of scaphoid fractures healing. We used to think that dense bone we used to think that the dense bone was a sign of avascularity, but it actually can be a sign of healing when you're adding new bone on top of dead bone. And biopsies have also showed that with non-unions, the proximal scaphoid tends to have denser and thicker trabeculi. That's kind of the normal process in a non-union. It doesn't happen quite as much distally. So you showed this case series from Mark Cohen and you and others. And I think you emphasized that with screw placement, you really don't need the additional stability. With K-wires, is that also the case, Jesse?
No, I don't think so. If you've really had to correct this humpback deformity, I think it may be better to have something stronger on the volar side. There's a little cortex.
Kyle, years ago, Jim Strickland and I had a couple cases. Tim Herbert came to Indianapolis to scrub them, and we'd signed the patients up for distal radius bone graft to the scaphoid. And he said, no, 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 you need an iliac crest bone graft. So does it matter? Do we need iliac, or is distal radius fine? Is there any evidence that one's better than the other?
No, I don't think it does matter. And I don't think there's any high level evidence, certainly. I think most of it is anecdotal, and some of it is just dependent on the series that were reported and what they used. In my practice, I honestly haven't used iliac crest bone graft for scaphoids in well over 10 years, and I don't think it's affected my outcomes. It's certainly nice for the patient and also from a surgical technique standpoint to have the donor site right next to your recipient bed. You don't have another site to work with, and for patient morbidity after surgery, there's no comparison. So I think that distal radius graft is certainly sufficient.
I'm glad you said that. Thank you. So Jesse, this is really simple. You put a screw in, and most of these conical screws do compress. And how do you judge the length of the screw? Do you take 2 millimeters, 4 millimeters, 6 millimeters? Does it matter? How do you prevent yourself from inadvertently putting in a screw that turns out too long?
To answer the first part, I always try to go 4 millimeters less than what it seems to measure. Secondly, I'm not sure that these screws really compress as much as they were touted to compress. So I don't worry so much about compressing down to lose the realignment when using handheld graft per se.
So just supporting it.
Yeah.
So it is an issue, Phil, when you're in the operating room trying to figure out how to reduce it. So yes, hyperextend and only deviate. Oftentimes there's a cortical shell that's still intact that you can use to judge it. But what other tricks, or what do you think we can use to assess the reduction? And then I'll pass off a question to Kyle about how we deal with rotational alignment.
So I think that rotational question is an important one, but I'll leave that to Kyle to answer. I frequently like to pin the lunate at neutral, as many of others have commented, and Jesse pointed out with one of the cases, you can get into a DZ deformity, and so realigning the lunate and pinning it to the radius, and then effectively maximally extending the wrist and only deviating, and I think that can give you the size of the graft. But I think you also have to assess the reduction looking at both fluoroscopically and clinically the chondral surfaces to make sure that it just lines up and looks like a scaphoid. And I think as one's N of doing these increases, I think visually, I think I've gone up my learning curve there and learned a lot better how to assess that reduction.
What are your thoughts, Kyle, on rotational displacement?
I agree a lot with Phil's last statement. I think that as you gain experience, you just get to recognize what a scaphoid should look like. We don't always want to just go on our gut feeling, but I think there's some value to that. And a perfect illustration of the rotational malalignment that we often see is in that second picture from the left with the yellow arrow that you're showing. And it, certainly led to union, and you can see a screw in good position, but the scaphoid just doesn't look right. There's too much curvature in the mid portion leading to the distal pole. And I think the clues are, If you look at the scaphocapitate joint, you lose the joint line in the distal half of the scaphoid instead of having that line continue all the way up toward the trapezium. And then if you look at the trapezial joint, the scaphotrapezial joint, you see triangulation there instead of a nice parallel joint between the distal scaphoid and the trapezium. And both of those are created when you get a supination deformity in the proximal pole and a pronation deformity in the distal pole, which often happens. And we have to think about those deforming forces. The FCR tendon, as we know, when we're going in to look at these from a volar approach, is really right down against the distal scaphoid, and it's pulling on that due to its fibrous attachments as it goes into the fibroosseous tunnel in the trapezium, and it just naturally creates a twist in that distal scaphoid. So one of the things, in addition to recreating length with our graft and putting in a screw, is you have to look very critically at that rotational alignment, because it can really have an impact on motion at the scaphocapitate joint.
Yeah, so this just outlines the trouble we have in viewing the scaphoid intraoperatively. A lateral X-ray doesn't show it. An AP will show you better the scaphocapitate interface, and this so-called Bora view for the, which is basically an AP of the fourth and fifth carpal metacarpal joints, will give you kind of a quasi lateral. Jesse, you know, some studies from Sweden has suggested with scaphoid fractures that oftentimes there's actually scapholunate tears or instability as well. I mean, years ago, I thought you either break your scaphoid or you tear your scapholunate, but in fact, we know that scaphoid fractures are not uncommonly associated with scapholunate injury. Not always complete, but partial. Do you ever run into that with scaphoid non-unions? Certainly, it's been shown that that further affects vascularity, but is there something that we need to do at the time of non-union surgery to address that, or do you just fix the scaphoid and that's what we do?
No, I think the scaphoid fracture that occurred with a transscaphoid perilunate instability pattern may have a higher degree of soft tissue injury and the very small proximal pole. Because to get a proximal pole fracture, the scaphoid has to have lost some of its supporting soft tissue. And that's why the scaphoid becomes more vertical and the proximal third hits the dorsal rim of the radius. So as a general rule, no, I don't think you find scapholunate injury very commonly, but with the small proximal pole, it may be an avulsion type problem.
Kyle, Tom Trumbull, in one of his studies, suggested that central screw placement was an advantage to shorter union time in scaphoid fractures. It's easier to get when you place the screw from proximal to distal. But how about if you place the screw from distal to proximal? What tricks do you have for getting it central? Do you avoid over mobilizing the distal scaphoid? What should we do?
It's a good question, and I think there's certainly advantages to a volar approach and a retrograde screw placement, so I have no hesitation doing that. I do try to get central placement, but I don't always achieve it. I'll be the first to admit that. The tricks I use are I make sure I have the wrist extended over a bolster and then ulnarly deviated. That gives me the long axis view of the scaphoid. And then I will take a fairly generous chunk off of the volar proximal aspect of the trapezium in sort of an oblique fashion. So I leave the distal trapezium, but I go almost halfway down the articular surface of the scaphotrapezial joint to get good exposure of the center of the distal scaphoid. And I find that if I do that, and then you can use a little elevator or even put a skin hook in the trapezium to kind of mobilize it away from the scaphoid, you can usually get your entrance point into that sweet spot in the middle of the scaphoid. I do think you have to be careful in mobilizing the distal scaphoid not to dissect off the capsular attachments on the dorsal radial aspect, where we know that the main blood supply comes in, and that's sort of a sacred zone that you should never debride. But I think if you're just careful about your bony carpentry, you can usually get that screw where you want it.
Super. Jesse, this is an article by Lottie Nagy and Schweitzer from Switzerland looking at computer-assisted correction. While I've done this elsewhere, I've never done it to the scaphoid. Can you see a scenario where this really would be indicated? They generally showed better correction with this, but is this really taking it one step too far, or what do you think?
Yes, I do.
I was hoping you'd say so.
I second the motion.
But I want to make one point. If you look at the models here, one way to help in rotational realignment is trying to put a K-wire in as proximal as to the cortex, perpendicular cortex, proximal fragment, and the same with the distal fragment. And then you'll see the distal fragment is often pronated. And then by using the K-wire and elevating the, as Kyle talked about, extension and ulnar deviation, and then using the K-wire as a guide, you can help control your rotation.
Yeah, I've noticed, as Kyle mentioned, the scaphocapitate is a good key. And oftentimes when you get erosion and loss of bone, the cartilage of the scaphocapitate joint is still there pretty normally all the way up to the dorsal side. Another big question, Phil, you talked about CT. Do we always need CT before we turn someone loose to say it's healed or not? And, obviously it's progressive. So if you serially look at CTs, as Greg Summercamp has done, these non-unions tend to kind of progressively heal. And then Jesse, I'll turn it over to you. How do you assess sufficient healing to turn someone loose to sports? Because these are young individuals and the majority of them are involved in sports. So Kyle, thoughts on CT? Phil, sorry.
Kyle can answer the question. No,
okay, you could both do it.
So as
it's the third rail.
As I think Chuck Cassidy said on one of these earlier AO summits earlier, nothing's ever 100%. So do we always need CT? No, I don't think we always need CT. I think radiographs over time, over moderately long periods of time, can also be sufficient. Having said that, many of the problems in management with scaphoid fractures have to do with the demographics of the group that gets them. Typically young, very active people, and those folks tend to be quite mobile geographically. And so I tend to get a lot of CTs to document union around the time that I would anticipate healing, somewhere between, typically for me, 8, 10, 12 weeks. And so vast majority, but not always, would be my answer.
Jesse, turn them loose.
Yeah, I think that you need to have at least upward of 50 to 60, 70% of cortical bridging in order to be considered healed enough to go and be in competitive sports. For me, CT scan is very important when I'm treating a scaphoid fracture without surgical approach, because you really can't tell the extent of healing from dorsal to volar on regular x-rays. The other thing is, when you have a screw in place, you have a certain advantage, and if you're not seeing any radiolucency around the screw over time, that's another good tip, that it's pretty stable.
Dynamite. I'll stop sharing and I'll turn the mic over to Kyle. Aspects of vascularized bone grafts. Thanks, Jesse.
Hill, before Kyle starts, do you have time for a question or two?
Absolutely, yeah. I didn't see it in the Q&A, but
I know Chai has a question. Thanks.
Thanks, Marco.
I'd like to encourage the participants, please feel free to chime in for the Q&A. We're keeping tabs on that, so thanks.
Yeah, just a couple of comments and one question. In reference to Dr. Hastings' question about the concurrence of scaphoid and scapholunate, it's been described, Ian Braithwaite and Tony Jones, my old boss in Liverpool, published a small series of 4 or 5 patients about this about 30 years ago. But I don't recall any concurrence in non-unions. And the second thing was, we looked at concurrence of surgeon opinions on CT and whether we should be using CT to assess union. and we polled about 150 surgeons and the Science of Variation group. And what we found that when surgeons were given the same CTs of my patients, I think we did about 45 or 50 patients, they were reasonable agreement about the degree of union, but they had very poor agreement on the location of union. So even though we get CTs, I don't think we all agree with each other, which brings me to my question. We are all reasonably agreed that the scaphoid dysvascularity is not really predictable on the multitude of investigative modalities that we use. So that being said, should we really stop using the term avascular necrosis, and should we really be using the term dysvascularity? You know, Herb Braun Schroeder is a big proponent of that, and I teach my residents the same thing. Should we be teaching the next generation to start using the term dysvascular rather than avascular necrosis?
Well, I think that's a good point. We do know that the proximal 70% of the scaphoid is dependent upon the dorsal vascularity, but there's all kinds of capsular attachments. And as Jesse's pointed out, and all of us have seen, you go in and is there punctate bleeding? Is there not? And it's usually spotty and it's hard to say. And so a lot of it's peripheral. So I think it's a spectrum. It's not all or nothing. And probably there's always something still intact. We have another question from Benjamin Klippinger. Do you keep someone in a cast after a structural graft? So I'll toss it open. My view is that if it's with K-wires, then I cast them and realize that casting does not immobilize the scaphoid. With a cast, there's still significant micro motion that's possible. So all it does is diminish what someone can really do. With a screw, that's probably less of an issue and probably just a splint, unless the patient comes in with their pants halfway down and is totally unreliable. Jesse, any final thoughts? And then I'll turn the screen over to Kyle.
I think if you're talking about a non-union that you've realigned and put a wedge graft, I think that's takes a longer time to heal, and there's a certain concern about that. So I think it's a all for none. I not necessarily cast all the time, but I protect them with a splint for quite a long time until I'm sure that there's adequate healing.
Okay, Kyle, roll with it. Thank you.
Hey, Hill, can I just make a comment beforehand?
Sure.
This is Chuck. Just an interesting juxtaposition. So John Elfar last week said he does not get a CT in line with the scaphoid. And Phil was talking that he was pretty adamant about getting it in the plane of the scaphoid. Just wondering what people think about that.
Yep. So personally, I try to do that, but we have thin slice CT that's possible. So the important thing is if you don't get it in the plane of the scaphoid, you must ask for a 1 millimeter or 1.25 millimeter thin slice so you can digitally reconstruct it and manipulate it into the plane of the scaphoid. So I think it depends on the size or width of your CT cuts. That's my read.
So Chuck, I'm going to just clarify. So thanks for the opportunity to do that. I think the literature is clear. If you're looking for a fracture, that in the plane of the scaphoid is superior, but that's not our topic tonight. But I also think when I'm looking for union, particularly with a screw in place, I find it just easier to see. But I think for many non-unions assessments, I agree with you and Hill that I don't think it needs to be in the plane of the scaphoid.
I actually like it in the plane of the scaphoid. And for the longest time, I thought with our tri-spiral CT that we were getting it in the plane of the scaphoid. We're not. We're getting axials, and it takes just a couple of minutes to get it done. And you can reformat them. It's terrific to be able to do it, but I still am skeptical about it. I think that if the right CT is in the plane of the scaphoid for looking at deformity and union.
Years ago, we did a study and we used that and asked radiologists to define if they saw a fracture or not. And if it's not in the plane of the scaphoid, there were vascular channels that were interpreted as fractures. So it probably, when you're looking for a fracture, as Phil said, may be better to make sure it's in the plane of the scaphoid.
I think it just goes to what one dean said in medical school. Half of what we teach you is going to be correct and half of it's not going to be correct. The problem is we don't know which half is which half, and we're still learning. So Kyle, roll with it.
Well, I think everybody's kind of debunked the purpose of my talk, so I'm just going to leave now.
No, no, not me.
We've heard from all the previous speakers how you don't need vascularized bone graft to get scaphoids to heal. So I'm going to be the ultimate devil's advocate here and talk about why I do still find that there's some utility. So we'll talk a little bit about which non-unions might benefit from vascularized grafting. I'd like to talk about the anatomy, which is important for anybody who wants to do these because it's fairly complex anatomy from a vascular standpoint, and we'll learn some tips and tricks to how to do these properly. So here's the question. We've already heard the answer. Do all scaphoid non-unions need vascularized grafts? And the answer is of course not. Plenty of them will heal with compression screws alone. Some of them will heal better with some cancellous graft or a strut graft. But I do think that there are some grafts in which vascularized bone is advisable. And the features that make that more likely to be the case are when you have significant disc vascular changes in one or both fracture fragments beyond the normal edema that we see with every scaphoid non-union. I also feel that if there's a very wide zone of resorption, cystic degeneration leading to a lot of collapse, sometimes we can't rely on the blood supply being intact in that proximal pole, or there may have been prior mobilization of the distal pole, which could have interfered with the blood supply and may hamper union. In very proximal pole non-unions, when we know that the blood supply to that small fragment is tenuous, I think that I'd be more often inclined to use a vascularized graft. And I use them very often, as you'll see in a couple of clinical cases in a minute, for failed prior attempts at either ORIF or even failed attempts at treating non-unions, where I still think it's a salvageable situation. So this was the article that sort of sent us all along the path of some of these pedicled vascularized bone grafts from the radius. Prior to this, Hori had some series that he presented with simply implantation of arterial pedicles into a non-vascularized graft to try to supercharge it with blood supply. But the Mayo group came up with well-defined arterial pedicles based on the dorsal and volar anastomotic arches around the wrist, upon which they could harvest bone from the radius with an arterial pedicle, thereby creating essentially bone island flaps. And that's what these really are. If you look at how we code these, I code it as reconstruction of scaphoid, plus I use an island flap because this is truly a bone island flap from a plastic surgery standpoint. It's got an isolated arterial pedicle and a mobilized piece of tissue, in this case bone, that we're placing. So let's go into a case so I can illustrate this. This is a problematic case that we've all seen before. This is a 35-year-old man with a proximal pole non-union for 2 years. So this exceeds the typical 3 to 6 months when you think you might just be able to align this and maybe put a little graft in and put a screw in. You can see well-defined vascular change compared to the other bones in the proximal pole and significant displacement, and it's a very small fragment. So the criteria that we see are displaced, it's somewhat dysvascular, and I agree with Chai entirely that avascular necrosis of the scaphoid is probably best left to discussing Prizer's disease and not necessarily scaphoid non-unions. And it's very proximal. So Hill, how would you approach this in your hands? Do you think this would be a vascularized graft, or what's your technique?
Yeah, so most proximal poles don't really displace except over time. So this kind of suggests that it is displaced.
And it's a 2-year-old injury.
I know that in a series of 21 non-unions of the proximal pole, 90% healed with cancellous bone alone. But this is the kind of case that I would favor using a vascular bone graft. I mean, you're going to need some kind of bone graft in this situation anyway. And a vascularized graft is adjacent. So if you think you can do it easily and predictably, to me, it adds one thing and then the second thing at the same time. It does the graft and it gives you some assurance of vascularity. So I personally would. When we first started doing these, we did it on all these kind of cases. It was like everyone had to have it done. And as time has gone on, we've become more selective, but I would still lend towards that.
Yeah, I agree with you. And so that's what we did. And looking more carefully at the arterial pedicles, you can see that there's truly an anastomosis with a proximal arch and a distal arch here going around the ends of the carpus. And in this case, I chose the 1-2 ICSRA, which sits directly on top of the retinaculum between the first and the second extensor compartments. It's a very small vessel, but it's very predictable. And that has a reach which allows it to get to the proximal pole, but it's really not very practical when you go to the middle third or the distal third. And I'll show you some other options for that. It's a retrograde vascular flow in that you clamp the vessel proximally. Here's one of Dr. Gupta's beautiful anatomic slides showing you that vessel beautifully situated on top of the retinaculum between the first compartment and the second compartment. And the pivot point for this is right here as the radial artery proper sends off its dorsal branch in the snuff box. You see this little pedicle coming up along the back of the first and second compartment. That allows you to harvest a graft about 13 or 14 millimeters proximal to the articular surface, which gives you a long enough vascular leash to reach the proximal pole. And here's that same clinical case that we saw the earlier radiographs from. So here's my example of creating a trough in the fracture. You can just see the non-union. It's been realigned. So we've corrected the offset with the freer elevator here, holding that proximal pole in alignment, and created a trough in the scaphoid going down to, but not violating the dorsal cortex, or the volar cortex in this case, since it's a dorsal approach. And here you can see the vessels had been marked out on the retinaculum. This has been cauterized with a bipolar proximally, but it's been left distally, and there's a lot of tissue here, so you don't see that vessel skeletonized going all the way down to the radial artery. This is before we mobilize the first compartment entirely, and you have to release this fascia that forms the floor of the first compartment to free up that pivot point, which is right here. Here's the graft harvested, so now you can see that illustrated nicely where you have a cuff of tissue so that you don't harm the vessels, but it gives you adequate reach to now implant this. We elevate it, we try to take a graft that's larger than the recipient site so that you can use a smaller enduro and just carefully nibble away pieces of bone until it fits perfectly as a manhole cover inside that scaphoid. It's often very difficult to create a graft that fills the defect in all 3 dimensions, and so I don't hesitate to take a curette and to take as much cancellous bone as I need to fill any void in the remainder of the scaphoid beneath this graft so that we have full obliteration of all of the dead space. And here you can see this was one that I fixed with K-wires. This was a case done very early on. I think this is from 2007. And you can see healing at about 6 months with preservation of good anatomy. So this is one of the other cases in which I think that vascularized grafts may offer us some advantage over non-vascularized, and that's when you already have some prior attempt at getting this to unite. Again, proximal, not a very well-placed screw. It's very eccentric. It missed most of the sweet spot on that proximal pole, and it went on to persistent non-union. This is about a year after that earlier attempt. So Jesse, what would you do in this case? Do you think this is a good case for a vascularized graft, or what's your approach?
Yeah, I do, for the reasons that you've outlined. Some of the substance of this not proximal pole has been eroded by the screw, and it's a fairly limited amount of bone there. So I think that that's a very good indication for me. And the other thing is what you said about the first case, we didn't really address, is timing. A thing that's been there 2 years is pretty hard to get healed in any case. So a vascularized graft is good for that.
I agree. So in this case, I agreed with your points. We know that there's going to be a vacuolation of the medullary canal in the scaphoid from this largish screw and a small fragment, and we want to try to augment healing in any way we can. So I chose a vascularized graft, but there had already been dorsal surgery, which I anticipated was going to go right through my 1-2 ICSRA pedicle that I just illustrated, and we weren't going to be able to use that graft source. So in this case, there are other sources, and in this particular case, I chose the 4-5 ECA. So this is in the floor of the 4th and 5th compartments, and you can see this large vessel going up here, communicating off the anterior and posterior interosseous artery communication through the interosseous membrane. And it gives you a much larger vessel And you can harvest it so that you clip it proximally and you mobilize both elements of this pedicle so that you can get this entire length. So it doubles the length from your pivot point here to the articular surface potentially. And you can get these to reach all the way up to the base of the metacarpals if you need to with the 4-5 ECA on an extended pedicle. So here's where we harvest our graft. It's from the ulnar side of the radius. So here's the pivot point. Here's where you harvest it, and then you're going to mobilize this distally. And it's going to easily reach the proximal pole here. And so again, this is the dorsal surface, interosseous membrane, radius, and ulna. It's got a long extended pedicle. One of the tricks somebody asked, I think it was Hill, what do you do about compressing against the cancellous graft in the scaphoid when you put in your screw? Do you lose the longitudinal height of the scaphoid? And one of the things I like to do is, if I can, I put in 2 K-wire struts down the long axis off the center of the scaphoid, so I still have room to put my graft and put in a screw or other K-wires, but I've maintained the longitudinal axis with a strut so that if you're going to put a screw in here, you don't compress that out of alignment. Here's the 4-5 pedicle. Here we've clipped it proximally, and we can get this long extended graft. Here it is inset with K-wires again, in this case because of the very proximal pole, and also because they had already taken away a significant chunk of the medullary bone in the scaphoid. I packed that prior tract with cancellous graft. I inset the corticocancellous bone graft. And here we are at about 6 months after surgery. So there's the pre-op, here's the post-op, and here are the results showing fairly good motion for a complex non-union. So those are both dorsal proximal poles. What do we do when we have a mid-third where it may be difficult to get one of those proximal grafts all the way around and not only reach the non-union site, but correct a fairly significant humpback collapse? You can see the scaphoid distal pole here, fairly flexed. You've got a humpback collapse, you've got shortening. This is some vascular changes. Phil, what's your approach to this?
So Kyle, I can't correct a humpback very well, or at least that I'm happy with either of the 2 bone grafts vascularized that you demonstrated so far. So I do agree this is one that I would consider a vascularized graft, although I might not necessarily do it. If I did do a vascularized graft, it would have to be from volarly or either distant.
Right. Yeah, so that's exactly right. You can't really get those humpbacks to correct. And I completely agree with you that there's ample debate about whether we need vascularized graft to get this to heal or not. And in this case, I did choose to use it, but I chose a volar approach, which gave me better exposure, better ability to correct the deformity by using some joysticks to elevate and create a wedge defect in the volar cortex. And then just as we have the anastomotic pedicle on the dorsal radius, we have volar pedicles. And here's the periarticular transverse artery communicating on both sides. And you can also see that it creates extensions proximally. This just shows 1 or 2 little vessels, but there's a very, very rich anastomotic network in the deep surface of the pronator quadratus that has penetration into the cortex of the radius. So you can harvest these either on a pedicle on the periarticular rim, or you can use extension here, and I'll show you how that works. So here's another one of Dr. Gupta's slides. This is showing that volar communicating branch from radial to ulnar. And it shows you that you can pivot from either side based on that artery, depending on where you want to harvest your graft. So here we see that case. You can see the chronic non-union. You can clearly appreciate the collapse in the scaphoid. This is flexed, it's offset. And here is that transverse communicating artery, but here I've outlined a cuff of muscle, and my rectangular bone graft is going to be taken here with a cuff of pronator quadratus left attached to it, mobilizing those deep vessels and communicating with the arch. So it's usually about 1 centimeter or less from the articular surface. I leave a generous cuff to protect the vessels. And then the periosteum in this case has to be handled very carefully, because you'll find that the periosteum on the volar cortex is much less robustly attached than the dorsal periosteum. It slides off easily, so you have to really handle this very carefully, not to end up with your pedicle in one hand and your bone in the other. And here we see the result of that graft. You can see the donor site. This is at a year or more. You can see the donor site has filled in entirely. It was taken fairly proximally. And you can see correction of the humpback flaps quite nicely with a longitudinal screw and full bony healing. And I don't think you need a CT scan to call this healed in this case. That's my personal preference or my bias in this case. So one last case, we see another failure, but this time it's a failure with a distal approach. And again, an eccentrically placed screw, which may have contributed to the non-union or the persistent non-union. And you can see a fair amount of resorption. This is a very unstable screw in the scaphoid with a persistent non-union. So it's eccentric, instability and resorption. Is it reconstructible? It's debatable, but you don't see arthritis, either distally or proximally. You don't see a lot of deformity, and you don't see a lot of obvious sclerosis within the scaphoid. It's also, this particular case was a young active tennis player. She was in her 20s, and I didn't really want to have to do a PRC or a four-corner fusion in a tennis player in her young 20s. So from arthritis, bone stock, and vascularity standpoints, I thought this was reconstructible, and we'll just go through that quickly. You can see the same principles as last time. Here's a large graft, which we're then going to whittle down to fit the defect. You can see the joysticks opening up the fracture. And here she is healed, and this time I did get a CT because she's a high-level tennis player. I wanted to make sure she was healed before I let her play. And you can also appreciate over here that there's still a little defect in the central axis of the scaphoid from that previous screw. We packed it with bone graft, but that didn't heal, but she healed around it quite nicely and did very well. So we have both dorsal and volar sources for our pedicle grafts. I'll just make brief mention of the medial femoral condyle free flap, which is another source of bone graft for free vascularized bone graft reconstruction. It's not one that I use, but there are centers. Jim Higgins at Union Memorial has done a lot of these and published quite a bit on it. And there are some debates about the benefits and the downsides, and it's just something that I think each surgeon and each center has to decide whether it's something they want in their armamentarium or not. And I'm going to leave it at that for discussion of that. So the key take-home point is that not all non-unions do require these vascularized grafts. We've seen ample evidence of that, but there are features that I think make these somewhat preferable in certain clinical cases and augment the healing and may give you a better result in some cases than non-vascularized graft. And they require precise technique to preserve the blood supply and good stability in order to get them to heal. So I'm going to stop and turn it over. Thanks very much.
Hill, I think you're muted.
Had a couple of questions that have come up, so I'll go over a couple things, and in the sake of time, I may pass through a couple things. So one person asked, they've heard of Chris Mateline's volar graft. Certainly he popularized this technique in the European and North American literature. But here is an Argentinian hand surgeon from Tucumán, Jose Maria Rotella, who unfortunately passed away just last March, a year ago. And yes, the Kawai and Yamamoto and Braun techniques were based upon the pronator quadratus, but in fact, as Kyle's just shown, it's really not dependent on the pronator quadratus itself. I'll show you another picture too that Kyle just alluded to. So here you see the dissection by Carlos Seidenberg looking at the pronator quadratus flip back. And then here you see this plexus that Kyle has just talked about. Through dissections with Carlos, we found that the densest and the best cancellous bone was distal and ulnar. And by stripping away all the other vessels except the radial artery, when you inject it, you'll see kind of the area that's densely irrigated by these vessels. And anatomically, you'll see perforators where they actually go in. So this is what Kyle was just referring to. Another question was by Mark Reiner on, do you backfill the defect? So this was a slide recently sent to me by Carl Seidenberg. You see pictured up on the right here. Someone sent this to him after this surgery. Obviously, it had penetrated probably the radiolunate joint. But it brings up two questions. How do you safely harvest it near a joint? Do you put in K-wires, check it under fluoro, and then use that with your saw? And then Jesse, what kind of defects do we think about needing to backfill?
Yeah, I think.
Go ahead, Jesse, with that.
Oh, very important to use K-wire, not just for the radiolunate, but also the radioulnar joint. You don't want to violate that as well. Secondly, yeah, for contact athletes, and you've taken a big graft, I do fill it. I fill it with a type of bone cement.
I've always filled mine with just cancellous allografts, just pack it in. I don't know that it's absolutely essential, but it's certainly easy to do.
My experience is that I haven't, and I haven't had any fractures. So, you know, like most of the things we're talking about, there's not a lot of high level evidence for our approaches, but I think it's individualized. I think, as Jesse said, in a high demand athlete, you might be a little concerned about fracture. I do think it depends on where you harvest your graft. And we know that, some of those dorsal distal grafts, the bone is very, very thin, and I think it's more prone to fracture than if you're taking a relatively small graft from a proximal source on the volar side where you have a lot of rigidity around it. So I haven't found a need, and I guess perhaps I've been lucky. I haven't had any donor site fractures.
Kyle, I was mostly referring to like professional football players.
Right.
The last thing I would want is to do this operation and the bone heals and then they fracture through it. So
yeah,
better part of it.
Many of these are younger contact athletes, whether they're professional or not, they're still often contact. I put in a slide about trips about popping out the graft. I'll pass through this pretty quickly because we're running short on time. I personally take a small saw to make the cuts, and then I put osteotomes on all four quadrants to create a little space. And then with one osteotome on one side, I just lever it so the osteotome cracks the very bottom of the graft. And talking about this, Kyle advises using a small curved freer elevator to free up the very bottom of the graft so it pops out easily. I'll pass over this slide, and I'll show another case here, somewhat similar to what Kyle's shown, a 28-year-old that injured, initially casted, and then shows up with a 3-year-old proximal pole fracture. Kyle, again, is this something that's reconstructible?
Yeah,
it looks like a waist fracture.
Right.
And you see that on this view, it does look like a waist fracture with some collapse. But again, as shown earlier, there's kind of a vertical Blake type of deformity.
Yeah, these are tough, Hill. I mean, I would call this a juncture of the middle and distal thirds rather than a true waist fracture. And it's got a fairly vertical orientation on the CT scan. And one of the problems you have is just debriding adequately without leaving yourself only a rim of cortical bone and cartilage distally. So, like most of these, I think the decision, is this reconstructible or not, has to factor in both inherent features of the fracture as well as features of the patient. If you have a young, active, non-smoking, high-functioning patient with high demand and high need, who really wants to continue playing and doing their thing at that level, you might be more inclined to reconstruct this. In an older patient who's got less demand, whose occupation doesn't necessarily require full wrist extension, and who just wants to get this to heal and get rid of their pain, this might be one at 3 years out with that much change in the scaphoid and a small distal rim that I might say it's better not to try to get this to heal. The real answer to your question, will this heal? You never know that until you try, and it either heals or it doesn't. So that's the problem.
So I'll fast forward through some of this. So this case had a PCRA graft, as you see here, and as you just shown. And then this was the radiographs with a radial styloidectomy, the graft interposed and then put into position. We talked briefly about augmented surgical angiogenesis. There's a reference to the Horry revascularization of the lunate or the Fernandez revascularization. So without wasting too much more time, the panel in previous discussing it did think that at times there's a role for augmented surgical angiogenesis, adding a vessel or even adding a small vascular graft on top of a non-vascular graft. Several studies have shown that smoking definitely matters. The union rate in smokers is certainly less. Kyle, can you, in 2 sentences or less, do you try to dissuade someone from smoking, or you just give up and just advise them?
Well, I try to dissuade any of my patients who smoke from smoking. I have a brief, discussion with them about how bad it is for them in a global sense. I talk about its impact on bone healing, but I don't draw a hard line in the sand saying I won't fix your scaphoid if you continue to smoke, because I think that's doomed to fail. And I'm generally, in most cases, especially if they're smokers, treating adults, and they have to know the risks and then take their chances.
I think that we have a track record of not doing very well in that regard. Then lastly, it's already been alluded that longstanding non-unions greater than 5 years are hard to heal. It tends to progress. The waist fractures tend to cause the earliest arthritis. They tend to progress from radioscaphoid to scaphocapitate and then radiolunate. Jesse, what are your comments on an older person, someone wants something simple such as an arthroscopic distal scaphoid excision? Anything in a couple sentences or less to tell us about that?
Most important thing is what you're defining as older. But I think, yeah, I think that some of these with a big deformity, if the proximal half is flexed, and so there does have good cartilage on it, it just, you can't tell. So arthroscopically is helpful to judge that. Radial styloidectomy, excising the non-union distal component, and a scaphocapitate lunate fusion would be my approach.
And then obviously there are other options late with PRC or four corner fusions. Yeah. This is just a couple images from this case, looking at it by arthroscopy. So to kind of,
I'm sorry, Hill, in that same vein, Tom Fisher asked, what about a role of styloidectomy? What do you all think as panelists?
I use them liberally.
So you can see that there's often impingement of the scaphoid and the styloid. And so that's one of the simplest and easiest things you can do. Good question, Tom. So I'd like to bring things back full circle and open up a couple questions if there's anyone that hasn't entered into the Q&A. So this was our introductory case. And as Kyle showed us, he had a 1-2 ICSRA. You can see the graft here, and then the graft implanted. And obviously there was lucencies proximally and distally from the screw. So as Kyle recommended, this patient had K-wire fixation. You can see the radial styloidectomy that oftentimes I do as part of the 1-2 ICSRA. These are some Indian ink injections by Carl Seidenberg when he was with me, looking at where we found the best vascularity with some 12 millimeters proximal to the tip. And it's worth remembering that these vessels are really epiphyseal vessels. So here on the left is an adolescent I did a case on, and you can see distal to the physis, it bled nicely, but proximal it didn't. So until the physis closes, there's not a lot of communication of these distal vessels in the proximal one. And once the epiphyseal plate closes, then the area of vascularity based on these distal sources tends to increase. And so these are his CT at 12 weeks. So the take home, X-rays often lie, and CT can obviously be a big help in planning. X-ray sclerosis and MRI do not correlate with punctate bleeding, and sclerosis is oftentimes seen just with thicker trabeculi in the proximal pole that's still vascular. Simple non-unions with little resorption can be fixed in situ just arthroscopically with a small amount of autogenous graft. When you get larger cystic deformity, then you need to debride it as well as graft. And then as everyone has shown, larger defects with collapse really mandate extensive debridement that's most easily done in an open manner with an interposition graft and fixation. Most of these waist unions, non-unions, do heal with conventional non-vascularized grafts, and certainly proximal poles with minor defects also with cancellous graft. As Kyle pointed out, vascularized bone graft is particularly helpful with these proximal ones where there's significant erosion in the proximal pole that's ununited. Long-standing class 2, where you have collapse and fragmentation of the trabecular structure, and then particularly, as Kyle showed us, revision after previous attempts. The vascularized sources for small grafts are easy dorsal, and larger really demand a Palmer approach. And then lastly, beyond 5 years, you have to think seriously about attempts at reconstruction of the non-union, and as mentioned, pay attention to salvage techniques. In a series that Jenny Green from Australia looked up with Carl Zeidenberg and myself, 8 of the failures, most of these related to failure to correct deformity, smoking, and probably inadequately applying to a much too long-standing non-union, applying to a hammer when you know you just have a nail. So any questions from the question and answer board that we haven't really covered?
Yeah, Hill, there's been a couple. One is a good question about the role of distal pole excision for isolated long-standing non-unions. And another question about debridement advice in terms of how do you debride some of these non-unions, curettes versus burr, et cetera.
Okay, Jesse, have you ever done a proximal pole excision?
Proximal pole,
It's the distal
Yeah,
pole.
I've personally only done it once.
distal pole, yes. But I said in combination with a styloidectomy and probably realign the proximal pole and fuse it to the lunate and capitate. Diego Fernandez has a large series of those, and they work pretty well.
Jesse, if you have an intact scapholunate ligament, do you have to fuse it to the lunate? That should be, fairly stable. I agree with stabilizing it to the capitate because of the long-term instability.
It may not be, but you don't have a big interface of bone on the proximal part of the scaphoid. So it may be harder to fuse to the capitate, but yes, it could be.
I also think that's a situation that you have to warn the person that, I think that individuals' carpal kinematics are disrupted, and long-term, they're probably going to have further degenerative change, which may be perfectly acceptable for someone who's not a great candidate for something else. But I think that's a responsibility we have as well, because that's not an anatomic reconstruction. It's just a pain relieving operation.
Yeah, for me, the indication for arthroscopic excision of the distal pole is certainly a long-standing one, and certainly someone that has unfavorable prognosis for healing with any reconstruction that requires fusion. So, i.e., a smoker. It's much easier to do something that gives partial relief than to have a total failure of a limited risk fusion, for example. A question also to the panel about, are any special debridement instruments? Do you avoid use of power burrs? Do you do it all by hand, curettes, osteotomes? Do you use a saw?
I use a saw.
Any thoughts on that?
A saw to make a trough. I think it works very well, but I don't use power burrs.
Agree with Jesse. Saw for a trough, and mostly curettes by hand to clean out three-dimensionally if I'm not making a trough.
I agree.
Personally, when you have
one respect I disagree, which is when you get in and you have a porcelain fragment, either the proximal or distal pole, and you can't debride that with a rongeur. You just can't get anything else to work. And I'll use a round burr, a 4mm burr, and I'll turn the power down to about 3/4 so that you're just carefully debriding away that porcelainized bone. And then once you get down underneath it, you can use a rongeur or a curette to do the rest of your debridement.
Personally, I use a saw for large defects where you can make a nice trapezoidal or rectangular recipient defect, and proximally and distally, oftentimes a K-wire just to penetrate up and down into the distal scaphoid and proximal scaphoid to open it up.
Hey, Dr. Hastings.
Yes, Chai.
Did the panel comment on how they decide how to do the radial styloidectomy? Do you follow Siegel and Gelberman's guidelines? How do you decide how much styloid to remove?
Well, I personally take it all the way back to the origin of the radioscaphocapitate ligament. So you can take more dorsally than you take palmarly.
I also
Kyle?
think that if you look at the recommendations based on the size of the styloid, that's based on a styloid without an osteophyte
Sure.
there, and many of these folks will have an osteophyte. So I agree with Hill that the radioscaphocapitate is important. The length may be less important by, in terms of applying a number.
Hill, we have a couple more questions. In the case of non-union with residual humpback, how would you manage? Do people do dorsal osteophyte excision and capsular release or other options?
Jesse, have you encountered that? So a healed, I assume you're talking about a healed non-union, but it's healed with humpback deformity. And you alluded to a dorsal osteophyte that tends to be right about where those dorsal ridge vessels come in.
Well, I've really been reluctant to do scaphoid osteotomies to correct that healed humpback.
Dr. Lynch had a series of those.
Yeah, I know.
And Diego
and some
Fernandez
didn't
too.
heal. Some didn't heal. Diego Fernandez had his, but it's a few and far between.
Absolutely.
I don't think excising the osteophyte would impair vascularity to a healed bone and take the styloid spur off as well, radial styloid.
Rodrigo Bolaños, great to hear from you, my friend. Do you use K-wires and do you bury them? Do you leave them out? I personally do not like any K-wires through the skin at the wrist. So particularly with scaphoids, and particularly when you're going to supplement them with a splint, or more likely with K-wires with a cast, then I bend them over and bury them for later removal. Any other comments from others?
No, I agree with that. Yeah.
Yeah, so it's safer to leave them, I think, buried.
I agree. Hill, can I just make one comment about radial styloidectomy? I think you have to exercise some caution in using it as an isolated procedure. I've seen a few patients whose pain was actually worsened by a radial styloidectomy. It was almost like the body was trying to encapsulate the non-union to limit the motion, and then it was liberated and they had more pain. Whereas if you do a distal pole scaphoid resection, you simultaneously get rid of the non-union pain and the impingement pain.
We have another question. Any tips for removing a screw that is buried within the scaphoid, finding it and trying to get it out? I guess it depends on the type of screw. Phil, any thoughts on that?
One of the mistakes I've made is trying to use a cannulated screwdriver for a well-seated buried screw. I have broken the tip of the screwdriver off in the screw, and it's hard to just get the tip of the screwdriver out. So a solid screwdriver can be helpful. Most of the time when I'm removing a screw in a scaphoid, a headless screw in particular, there's a persistent non-union or something like that, so it's not as much of an issue. But I agree with the person who asked the question. That can be rather challenging. I hesitate to use something like a trephine, like you might use elsewhere in the scaphoid.
Sometimes if you put some bone wax into the hole of the screw and put the screwdriver, you might get a little bit of better grip.
Marco, Chuck, are we time up, or are we still able to field some more questions?
No, I really appreciate it. Wonderful job, guys. Hill, Jesse, Phil, thanks so much. Thanks.
Great.
Thanks, Kyle. I don't know. I don't see you anymore. He might have left already.
I gotta go.
Okay, Kyle. Thanks, buddy. And
okay.
And it was an outstanding session, and it's going to be hard to top this next week. But I'm sure Doug can put up a good.
Absolutely.
Thanks, guys.
Good job,
All
guys.
right.
Take care.
Thank you for
Phil.
arranging this, Chuck and Chai.
Thanks,
Great
everybody.
job.
Thanks for doing the heavy lifting on this session.
Yeah,
And
thank
Right.
you.
Good
Thank
job,
you.
everybody.
Thanks to our guests and for their questions. And just a reminder that the CME will be available after this whole series concludes. We look forward to seeing you next week. Thank you.